In a world of healthcare, where compassion is paramount, there exists a place that goes beyond the ordinary. It's not just about responding swiftly in times of crisis, it's about being a beacon of hope during life's most challenging moments. It's not just about treating an illness, it's about engaging your child's imagination and turning their visit into a memorable adventure. It's not just about a diagnosis. We make it our mission to ensure that you fully understand your condition while going out of our way to simplify medical jargon. It's not just about serving meals, it's about nourishing your body and soul with delicious and nutritious food tailored to your dietary needs. It's not just about maintaining cleanliness, it's about a pristine and hygienic space that promotes healing and well-being. It's not just about performing a surgical procedure, it's about meticulous planning and executing each step with precision and expertise. Our team of doctors, nurses, and support staff work in harmony, driven by the belief that exceptional healthcare is a combination of expertise and heartfelt compassion. Welcome to Clinics, where health and care meet.
Good evening, colleagues, and indeed, welcome to Clinics, where health and care meet. And we want to thank you for joining us once more for this weekly webinars that we hold for the last few years. And it's quite an exciting moment once more to be having another speaker who's going to be sharing something different from what we had last week. But before then, I just want to say that please note that these webinars are CPD accredited, and we request that when you join us, please, when you log in or you register, please give us your full details so that we are able to capture that information and submit it to our partners, and they can have it uploaded to the HPCSA, and that we are able to give you the CPD points per presentation that we are having every week. And also that note that these webinars are streamed live on YouTube, so you're able to, at any time, go back and watch this on YouTube. And hopefully in the future, we'll be able to get some training on YouTube or watching on YouTube and get CPD points if you missed the live webinar on Zoom. And so this evening, we're excited to have someone who has been here before, and we're glad that she's back again. And that's Dr. Tshegofatso Moeletsi, who is an expert in chemical hematology and microbiology. She has over 20 years of professional experience as a medical doctor and a pathologist. She's both a pathologist at Lancet Laboratories and also in charge of human resources in the Johannesburg South region of the organization. When she spent some time within this group of human resources, she developed a passion for HR, and that later led to being a regional pathologist who was also in charge of HR. And she regards this as a differentiator and a driver to ensure sustainable business success for the group. As indicated, she's a pathologist, obtained an MBCHB from Wits University, and then also qualified from the College of Pathologists Clinical in CMSA. And she also has qualifications in human resources management and financial management from the University of Cape Town. And so Dr. Moeletsi will be speaking to us this evening on the biomarker of infection, a summary. And it's something a bit different because we've been talking about patients, live patients in the clinical setting or what, but now we look back at what happens to this patient, what are the markers that indicate they are been infected. And so she'll take us back to the laboratory and also combine that with clinical work. Thanks a lot, Dr. Moeletsi, for joining us this evening, and we looking forward to this presentation.
Thank you so much to firstly the Clinics group and Dr. Billa for the invitation. It is truly an honor to actually be presenting to you guys today. Let me share my screen and start without any further ado. Right. Good evening to everyone. I hope I'm audible, and I hope you can see my screen. If I can get an indication so I can start that talk.
Yeah, you're audible and you can see the screen.
Okay, perfect. Thank you very much. And again, today's discussion, or should I say presentation, is just to take a little bit of a breath and look at how we can actually look at whether or not our patients have infection, which tends to be quite an issue in patients presenting with either fevers or any sort of inflammation. And today's talk is just a summary of some of the old things that we learned back in med school and some of the things that we're using in clinical practice today. So just to take you through as to why, in fact, it matters to have infective biomarkers. I'm afraid my talk is not moving as expected, so just excuse me as I try to see that. Gamo, we were fine earlier. It's yeah. Okay, we're fine. We're fine. We're fine. Okay. Yeah, it was just delayed. Okay. Perfect. All right, so then I can carry on. Just as an introduction, why does it matter that we can have something that is a stand-in or a surrogate to indicate to us whether our patients are infected? It matters because, as we're well aware, it takes a little time before, from the lab side, we can culture something back and tell you that this is what's ailing your patient. So, and also we know we have very high rates, in fact, of antibiotic resistance, and it's important for us to use antibiotics prudently, otherwise we actually exacerbate that problem. We also know that there's high mortality rates in patients with bacterial infection if those infections are not treated quite quickly. As a result of this, surrogate markers for infections are actually quite paramount in bridging these sort of challenges that I have highlighted. What we also know, in fact, is that we don't have any gold standard biomarker that indicates presence of infection. So for obvious reasons, there's more than one biomarkers that is at our disposal to actually try and help us in our quest to find out whether our patients are infected or not. What we also know, in fact, is that about 30% of our patients with sepsis, hardly a cause is found. And in the rest, we are actually left wondering whether or not this is infectious or non-infectious. What we do know as well, in fact, is that sepsis is a very complex disease entity. And because of this, you can understand why you will not have one single ideal marker that can give us the answers we're looking for. So why do you use biomarkers other than for reasons mentioned? How do we use these biomarkers? So these biomarkers can actually help us in infection differentiation, meaning firstly, not just whether or not an infection is present, but also what type of infection or inflammation is present in our patients. Is it bacterial? Is it viral? Is it fungal or other? They also help us with risk stratification, early risk stratification, because with some of these markers, depending on how highly elevated they are, you can therefore prognosticate and decide whether or not there'll be severe disease outcomes, or in fact, our patients are doing better with disease evolution and resolution, and therefore more favorable outcomes will be gotten with that patient. They also help us optimize antibiotic usage. And what I mean by that is that they help clarify whether an antibiotic should be started and when an antibiotic should be used, and as rapidly as an antibiotic is needed prior to confirmation by culture from the laboratory. So that's why we actually have them. So I'm going to take you through these four. I do have, however, at the end of the talk, a list of the new biomarkers that are not yet clinically available although they have promising, in fact, results in clinical trials. So I'll just mention those. There's quite a few. They're not all equal, as we know. Right. So we'll start with our good friend, procalcitonin. What is procalcitonin? Procalcitonin is a precursor protein for calcitonin. It is encoded by the calci1 gene, and this gene, in fact, produces procalcitonin, and this gets cleaved on stimulus by cytokines. It is in the main for calcium control found in the thyroid cells, C cells to be specific. And usually it is found in undetected levels, because in the thyroid cells, if there is no infection, inflammation, and the thyroid doesn't in fact release it, the levels start to increase, and these increases, in fact, it is as a result of parenchymal release due to infective or inflammatory stimulus that, in fact, increases production of procalcitonin, as it were. So it's thought that procalcitonin is not only found just in the thyroid C cells. It is also found in endothelium, in any other parenchyma, and will only be released from these into serum post an inflammatory response, in fact. So this is just to demonstrate the discussions here, where in the thyroid, in the blue, is where you're finding production, and this production is regulated for calcium homeostasis. Whereas with regards to inflammatory stimulus, you will find this, in this case, is an adipocyte, but it could be anything in the lung. It's also thought of to be found as well in GIT cells, in fact. And on stimuli, either it being an infection or trauma or a cell damage of any kind, then the promoter gene will then be activated, and a PCT will then be produced. This is a graphical representation of the kinetics of production of CRP in relation to cytokine stimulation, as well as it relates it to how quickly it rises and falls in comparison to CRP. And this graph actually helps show how much quicker in relation to the cytokine stimulation, PCT, which is in the blue, goes up and falls, as opposed to the CRP, which we'll discuss now in detail. So this gives you an idea of the rise and fall of both molecules as biomarkers of infection, inflammation. And please notice I'm saying infection, inflammation, because you will see in a diagram that I'll show in a bit that even though it is thought that PCT gives a better specificity for bacterial infections as opposed to CRP, which is true, it is also still raised in other inflammatory conditions, just like a CRP is. It is thought to give a better specificity for bacterial infection, because it is thought that on the promoter gene, there's a binding site for lipopolysaccharides or endotoxins of bacterial cells, and that's why it seemingly was preferred or was said to have a better, higher specificity for bacterial infection as opposed to CRP. The graph has shown this already, the peaks of PCT post-stimulation and its half-life. What is important to note here is, in fact, that the extent of increase of PCT correlates with the severity of illness, or in fact, the severity of the stimulus. So the higher the PCT, the more severe the illness. Decreasing concentration also correlate with disease resolution, meaning the stimulus that caused its increase is now resolving. It is eliminated from the bloodstream by proteolysis. However, there's a small kidney clearance. And this might be actually quite relevant in patients with severe chronic kidney disease. It is also important to note the rate of fall of PCT post-resolution of the infective stimulus or inflammatory stimulus. And it's that with effective management and therapy, it's expected that you will have a decline of about 30 to 50% each day. And this becomes very important when you look at clearance levels of this molecule or non-clearance of this molecule as a measure of response to therapy. All right, so how do we use PCT in the clinical setting? I've already mentioned that it helps in typing of the infectious stimulus that our patient might be having, keeping in mind, in fact, that even though it might also show some generalized inflammatory process, it does have a better predilection for bacterial infection as opposed to CRP. It is also used in the post-operative time where you will understand the CRP will be slightly raised post the surgery to try and figure out if our patient who's not seemingly improving has a post-operative infection or not. And there's extensive studies where it has been shown in an outpatient setting to actually aid in initiating antibiotics or not, and also in terms of referral of patients to a higher level of care. It's also used, in fact, in antibiotic stewardship programs as an aid to deciding on whether treatment should be started or not, as in there's a higher likelihood of bacterial infection in a specific patient as opposed to a viral infection, and therefore treatment should be started, or stopping antibiotics where, in fact, it is used to check if there is good response to therapy by looking at declining levels of PCT. There is actually clinical trials that have shown decrease in hospital days spent if PCT is added in the antibiotic algorithms in patient management, and even number of days of use of antibiotics have decreased if you add PCT as part of the decision-making in your treatment algorithms. PCT has also been shown as a prognostic marker. In fact, where if PCT is measured and is shown to be high in patients at admission or at ED, you can almost predict that those patients will have worse outcomes. But because of variability of study populations looking at this 28 to 30-day mortality rates using PCT, and the fact that there's various definitions as to what the mortality limits that they're looking for or morbidity limits that they're looking for, there is no formal recommendation to use a PCT as a prognostic indicator. It is, though, associated with poorer outcomes and higher mortalities if levels are high. In this slide, I just wanted to show you how PCT is being used in treatment algorithms in patients with lower respiratory tract infections, where it actually aids in initiating antibiotics, and in cases like this where in fact PCT can be used to follow up those patients to see if there's adequate response to therapy. So in some of the facilities, PCT is an integral part of their patient management where infection is in fact suspected. From our lab, we will get something that gives you this type of results where we actually try to give you a guide with regards to cutoff limits as to where more or less your patient is likely to be in terms of the likelihood of infection or severe sepsis or not, to just try and aid in that decision-making together, obviously, with the, in fact, clinical picture of your patient. Like every other test in the lab, PCT has limitations and there's challenges. And one of which is that, in fact, because of no method harmonization, what I mean by that is that not all methods used in labs to measure PCT are all made equal. Currently, there's 42 approved, FDA-approved assays, and not all of them perform accurately. So that obviously limits the recommendation in terms of cutoffs and when to use it in various population and clinical states, because not all methods perform the same. Also, there's issues regarding specificity for sepsis, as mentioned, because it is also an inflammatory marker, not just specific to bacterial infection like we initially thought. There's also lack of consensus regarding timing of tests. So do we take all PCTs on admission, or do we take 2 hours post-admission, or at various points? So there's lack of consensus in terms of guidance so that we can use PCTs results in various clinical decisions. There's also lack of consensus in when to use PCT in various clinical settings. For example, there's limited evidence in pediatric and neonatal populations, where in neonatal populations, depending on the hours the baby was born, PCT levels can reach as high as 10. I'll show you in a table. Yet the baby has absolutely no infection, and these are thought to be as a result of the birthing process that causes some pro-inflammatory modulation or activation, and therefore you might have in a normal child, in a normal neonate, increased PCT levels. So it is important to remember in pediatric and neonatal populations, unlike in with CRP, which we'll look into just now, there's not enough guidance there. There's also reduced data regarding use in lower respiratory tract infection in some populations as well, where in immunocompromised, for example, of VAP patients and critically ill patients, we still need more data to support use in initiating therapy, whereas we can use in decision-making in terms of cessation of therapy. So in some of those populations that you do need to keep in mind that you do need a bit of guidance, and you must be aware that things are not as straightforward. However, still a good biomarker nonetheless. This is a table that just gives you a depiction of what the levels might look like in neonates, just simply because of the birthing process. So you can see here, between 18 to 36 hours, your PCT is as high as 10. So you might be thinking your baby is having a septic shock there when they're actually not having. The other things that we as lab people also seem to not necessarily communicate well with our clinical team members is that not all testing assays are born equal. At the moment for PCT, the Brahms PCT is considered the gold standard, simply because the initial clinical trials that actually established the PCT clinical decision points were used on PCT measured with the Brahms method. And so it is important for us to be aware that that's what we use as a gold standard, but there's many other types of assays that are not necessarily Brahms and haven't been verified and correlated in performance to the Brahms method. What is important for the clinician to note is that you need to use the same method to trend PCT values for the same patient. So today you can't measure in my sister lab, which you're not sure what the methodology is, and then tomorrow as another lab, and then think you can use the trend in that PCT. You need to confirm if the methods used for measurements are actually either correlated to the BRAMS or similar method being used, so that you can trend your PCT levels. By trend, I mean using more than one measure of PCT level to decide on whether there is improvement in the clinical condition of your patient, or whether or not you need to actually adjust therapy because there's poor clearance, in fact. And also what you have to remember is that the PCT levels correlate with the presence of the stimulus still, not so much the rate of clearance of PCT. So for as long as the stimulus is still present in your patient, it might be reflected as low clearance, as in PCT levels not declining. It doesn't mean necessarily that there's poor clearance of it. It just means there's continued stimulation of production. Also, you have to remember, in fact, as mentioned, that there is other scenarios that can elevate your PCT outside of bacterial infections, as mentioned, and also age-specific reference ranges are quite important, especially in the pediatric population, but more so in neonates. What you have to remember, in fact, that elevated PCTs have generally correlated or high, very high, with poor outcomes, even though there has not been a particular concentration of PCT recommended to indicate a poor prognosis. So the higher the PCT, the more likely the adverse outcome you will get in that patient, even though there's no specific concentration that says if your PCT is 20, you're definitely going to have higher mortality. So please keep that in mind. So in summary, for PCT, in order to actually have improved outcomes in patients suspected of having inflammation, especially bacterial infection, it actually adds in a favorable way to improve outcome if you're using it in conjunction with your stewardship program in an algorithm to decide whether or not your patient has infection and therefore requires an antibiotic. The next biomarker is CRP, a C-reactive protein. C-reactive protein has been around since 1930. It was discovered by two gentlemen after noticing that patients who actually were infected with pneumococcus, their sera, when reacted with the C fraction of the pneumococcus reacted with their sera. So hence C-reactive protein, just like PCT, is also an acute phase reactant. I know most people don't actually highlight the fact that PCT is an acute phase reactant. It is an acute phase reactant. It doesn't fall in the complement group or the coagulation factor group. It falls in the, in fact, in the miscellaneous group, just like PCT does, of acute phase reactants. What those are is those proteins that go up in response to either an inflammatory or infective stimuli, either it being damaged cells or fungi, bacteria, virus, and such. And those go up as in response to pro-inflammatory cytokine stimulation. So it is normally below 10 if you use a normal, not a high sensitive test, and also can be raised like any other acute phase reactant as a result of inflammation caused by anything, inclusive of infection. It rises rapidly as per the diagram here, but it doesn't rise quite as quickly, in fact, as the PCT does. And it peaks much later than the PCT does, and it takes a little bit longer, even though it's quite fast. I mean, initially it was seen as a very fast marker of acute infection until PCT came along. So it still has some utility, and because it's been around for so long, it has been extensively more studied than PCT has been, and has been in use far longer than PCT has been in use. The diagram below here just simply suggests that it gives you a structure. A structure of the PCT is a pentamer. In fact, it has 5 subunits, sub-equal subunits joined together. So that's what it looks like. What you need to note is that just a normal CRP test, the concentration would give you will be anything between 5 to 20. So that's the normal usual concentration that will give. But we know more than 10 is usually indicative of inflammation. However, we do have ability to measure with a high sensitive CRP test. High sensitive CRP test is a similar, except it has ability to measure at very low levels with and it is sensitive to pick up small increases in CRP levels. So normal adult CRP is thought to be just below 10, except if you're using high sensitive CRP. And we've known that, in fact, 10 can be very deceiving. There's lots of studies, especially in relation to metabolic inflammation, where a whole lot of studies that have gone into cardiovascular risk has looked at very minimal increases in high sensitivity CRP, and those have been correlated with higher mortality rates. So that relates basically to just metabolic inflammation that is going on, that is not obvious and overt, that might be missed, in fact, by using a normal sensitivity CRP. So even though I have said normal adult levels is anything below 10, we'd prefer below 5. However, if you have a CRP level below 10, it doesn't rule out the fact that inflammation is happening there. So if you never use high sensitivity CRP, for example, you might miss some of these patients. Infections or inflammatory disease states can cause a CRP level rise, and this can happen quickly, between 4 to 6 hours, it's said, and up to 8, and it can peak to even over 400 in just 48 hours. So it can peak quite quickly. And that's important to note, and that's why it was a very good marker to use, because you can then respond to whether or not that patient needs treatment quite quickly. What you need to remember with CRP, just like with PCTs, it's unaffected, unlike our good old friend biomarker ESR that I will not be covering in this talk. It is unaffected by low HBs and protein levels and red blood cell shape and charge on the red blood cell, unlike ESR was, which is what was used in the past. You do have to remember that the distribution of CRP doesn't follow a normal curve distribution. So the older one gets, the higher the CRP tends to creep, even though it stays below 5 or 10. So it is shown that people over 70, in fact, even though they started with a CRP at around 0 point something, tend to have CRP sitting at 2, and that amount tends to increase the older they get, to even 90, or what they call centenary patients having much higher CRP compared to before, even though there's no obvious infectious cause demonstrable. We also have to remember that females tend to have higher levels of CRP, and in certain races as well. So Black people tend to have higher levels of CRP as well, even though it's within the normal limit. So keep those in mind as you're interpreting, in fact, your CRP level in your patients for various medical reasons, as alluded to. With this very fuzzy, now that I look at it, diagram, I was just trying to demonstrate just simply how everything fits together. You can see bacteria as well as damaged cells and viruses cause stimulation of macrophages or dendritic cells in tissue, and these are the ones responsible for a cytokine-mediated communication that results, in fact, in these acute phase reactants being produced. To mention as well is that it is actually not clear, other than as an acute phase reactant, exactly what the role of PCT is, as opposed to CRP, which in fact, other than has a pretty defined role in infection. So it is thought to be involved in complement activation. So it binds, in fact, to pathogens or damaged cells, and it actually activates complement, and this eliminates these from the system. In fact, it also is used for opsonization, which enhances phagocytosis by the very macrophage that actually produce cytokines for CRP production in the first place. There's also thought to modulate inflammation, so it interacts with immune cells and also cytokines to regulate the inflammatory response as well. So those are its clinical functions, other than the ones in PCT, where at this point we are not quite sure. I hope the diagram has also demonstrated, in fact, just how complex the immune response is, and just how interconnected everything is. That is why it's not as easy as we would like to have to differentiate markers that only will be raised with infection as opposed to generalized inflammation. What else does CRP do in the clinical setting? It also helps us to detect infection, as discussed. But we also use it not just in an infective setting. We also use it as in inflammatory disorders, such as rheumatoid arthritis and inflammatory bowel diseases, in fact, to try and detect whether or not the patient still has a disease active, and just whether or not they are responding, once we've detected that there's disease activity, to the management that we'll be giving them in a purely inflammatory disease perspective. As I said as well, in metabolic inflammation, where cardiovascular risk assessment is needed, high sensitivity CRP is used there, and high levels are associated with increase in cardiovascular risk. So it is, in fact, a very useful marker in assessing cardiovascular risk. It is also used for post-operative monitoring, just to see or evaluate the surgical trauma that a patient might have suffered. You know, post-surgery, because there's damaged cells, that your CRP levels will be raised there too. And so if you are trying to use CRP solely as a marker for infection in a post-operative period, you need to be aware that trauma or surgery itself will raise those levels. So take that into account. It is thought as well, in some instances, to be used as a prognosticating marker. However, not in the same way as the PCT is being used in infective diseases. So it's thought to be used as a prognostic markers in certain cancers and in kidney disease, just to provide, in fact, insight into patient outcomes. For example, you can see, therefore, in an inflammatory setting, that if you've given your patient treatment and they're not actually responding as indicated to you by CRP and many other things, then you can therefore see that there'll be adverse disease outcomes, and you can actually prognosticate with that patient, as well as in cardiovascular risk, as discussed. It is also used in antibiotic stewardship, just like PCT is, and is also used in initiating or cessation of antibiotic treatment. And there's vast amount of studies that have gone into using CRP in the outpatient setting to aid primary healthcare practitioners to decipher, when patients appear to them, even in the pediatric population, as to whether or not antibiotics are necessary. So it's been used to such an extent that there is actually point of care CRP measuring assays that are in doctors' rooms or in clinics, and these are incorporated as part of the algorithm to decide whether or not the patient should in fact be started on antibiotics or be referred, or is simply just a viral infection. Of note, actually, viral infections tend not to cause a very high CRP, even though there's an inflammatory process going on. They tend not to cause very high CRP levels. It is thought that this is as a result of interferon gamma that gets released due to viral infection stimuli in inflammation. Also, what needs to happen, there's lots of studies that look at PCT as opposed to CRP in lower respiratory tract infections, but these are not looking at both in comparison in one study. So it's usually looking at various studies that looked at PCT and then others that looked at CRP, and then trying to compare which biomarker is better than the other. But because, as we said, the studies are not all uniform, patients aren't uniform, and in fact, disease states aren't always uniform. So it's very difficult to have direct comparisons between the performance of CRP and PCT. And in hospital settings, both tests are being used in patient management. Also, even though CRP is actually readily available, as I said, there's even point of care tests available to measure CRP, and also is a lot less cheaper. It's a lot less cheaper than PCT in measuring. So it seems at the moment that CRP would be a more cost-effective biomarker to use, especially in poor resource setting as opposed to PCT. But we do need direct comparison studies for cost-effectiveness of use in both these biomarkers. Excuse me. So these are just some of the instances where you will have an increased CRP. As mentioned, and inclusive of that is even in chronic allergic conditions with severe allergies can also cause an elevation in the CRP as well. All right. Ooh, that actually is projecting quite poorly. But with that study, I was just trying to demonstrate the good and bad of C-reactive protein in terms of trying to help us decipher whether or not there's infection. We know that it's not specific for bacterial infection. Any old infection or inflammation can raise it. So that's the bad side of PCT. However, PCT levels and presence in bacterial infection is consistent in most studies when people are looking at its utility. And so that's, I guess, the good side of it. And also it's been looked at in a whole lot more various setting as opposed to PCT, which is mainly looked at in the main in a hospital setting or resource-rich setting. Also, not this a reduction of overall antibiotic use using PCT, especially in the primary healthcare setting, using CRP, sorry, as opposed to not using it in a primary healthcare setting, which also has actually helped in reduction of abuse of antibiotics and therefore resistance forming as a result, and the cost effectiveness as discussed. So this is a study that was done on pediatric population, trying to see if you incorporated PCT in your clinical management of CRP, in the clinical management of your patient in an outpatient setting, whether or not this will result in adverse outcome, meaning will you miss serious illness or not. And it's shown that if you use certain cutoffs, like a cutoff below 20 with vital signs as well, and clinical features, if it's less than 20, you're less likely to miss, because only 6 serious infections, in fact, were missed. If you look at those above 75, you can see you're in fact picking up quite a lot of serious infections if you used higher levels as your cutoff to decide whether kids have serious infection or not. And also to note that a CRP less than 5 rules out serious infection in pediatrics, and therefore these can avert unnecessary referrals of pediatric patients from GPs to a higher level of care. So can be used in that setting. Right, moving along from bacterium to now fungi or fungi, however way you want to pronounce it. So FungiTel is a test, unlike a biomarker manufactured by the body, our own physical bodies. A FungiTel isn't produced by our own bodies. What FungiTel actually assay does do is in fact look at components of the fungal cell wall, and that's if you detect those in the bloodstream, then you are therefore diagnosed to be having invasive fungal infection. Why did we even embark on having an assay such as FungiTel? Why is it important? Why can't we just wait for the lab to grow a fungus and tell us that this person has this fungus and this is the issue? Actually, it takes even longer to culture a fungus than it does to culture a bacterium. And you can see, in fact, how problematic this will be in a very sick patient because fungal infections are associated with significant morbidity and mortality. And morbidity can be as high as 47% in those patients with infective or invasive fungal infections that are missed. And also what is important to note is that invasive fungal infections don't actually, especially candidiasis, doesn't have a specific presentation. So they look sick like any other. So you might miss some of those. And if they do have signs specific to invasive candidiasis, it's already too late in the disease process, in fact. And most of those patients don't do well in those instances. And also, it's actually quite difficult to distinguish colonization from invasive disease in these fungal infection in patients. So you do need a little bit of help whilst waiting for direct confirmation, or sometimes even if you have confirmation in a case where the lab calls you and says there is presence of a fungus, it's FungiTel. Actually, you will see how it in fact is helpful in terms of distinguishing colonization from actual infection. And also what's important is that we know, in fact, that a fungal infection have significantly more higher mortalities as opposed to bacterial infection. And in fact, blood cultures for fungal etiologies are only positive in 50% of cases of invasive candidiasis, and in some cases as low as 30%. And in aspergillosis, the picture looks even worse, and hence the need for a surrogate marker like FungiTel. Also, the use of prophylactic antifungals make it very difficult for us to be able to culture these fungus from blood cultures because the patient has already been exposed to an antifungal. We also know that timing of treatment is very important if we are hoping to improve outcomes in these patients. And from all of these, you can see why, in fact, there's a critical need to also identify patients with invasive fungal infections early on in order to, in fact, improve those outcomes. So what is, in fact, FungiTel? What FungiTel is a semi-quantitative test. What it means is that it can give you a number, a quantity to a point. And this test, what it does, it detects the presence of the 1.3 beta-D-glucan component, which is a part of the cell wall of the fungus. So you can understand ordinarily in humans, you shouldn't be detecting 1.3 beta D glucan unless there's some other unexplicable alien reason as to why you normally have that. But in a normal situation where there is no invasive fungal infection, there should be zero detection of the beta D glucan. So the minute you detect beta D glucan in a patient, you can give a presumptive diagnosis of an invasive fungal infection, because if it's detected in blood, if bits of a fungal cell wall are detected in blood, it therefore means that there is a presence of the fungus in blood. So it means nothing to clinician, but it's a kinetic colorimetric test. So we look at the color change in order to say whether it's positive or not, and the severity of the color change will tell you it's correlated, therefore, to a particular quantity that gives you an actual concentration in the end. So it ranges from not detectable or undetectable, as in no beta D glucan found in the bloodstream, to as high as more than 500 picograms per ml. So these are most of the pathogenic fungi that have beta D glucan in their cell wall, and they are listed, all of them there. What is important to remember is that there are some fungi that do not have beta D glucan in their cell wall, and if in those patients, even though there is invasive fungal infection due to those specific species, your beta D glucan test or fungitel test will come back negative. And these are the Mucorales, Mucoabsidia rhizopus categories. And because of the thick cell wall of the cryptococcus, the capsule, of it's very thick capsule of the cryptococcus, it makes it hard as well to detect cryptococcus beta D glucan. So you can have a negative beta D glucan test or fungitel test in these patients as well. Right. Also, in some, sorry, that there's a typing error there. In some species of Candida, like Candida parapsilosis, you can get lower levels of 1.3 beta D glucan. And so just keep in mind, because 30% of candidal infections in neonates in ICUs are as a result of Candida parapsilosis. Also, we see a lot of Candida parapsilosis in our private hospital units where fluconazole has been used as either not empiric therapy, but used to actually clear colonization, just simply as presumptive therapy as well in some instances, which gives predilection for parapsilosis to be the main candidal species in those units. So also the baseline levels in unaffected children are as yet undetermined. So you need to keep that in mind if you're going to use it in the pediatric population as well. So you need to use it in conjunction with others, in other clinical and other tools at your disposal to tell whether or not there's likelihood of fungal infections in pediatric, especially the younger the baby, the more so this applies. So this is the values you would get from the lab. If it's less than 60 picograms per ml, it's reported as negative. It's more than 80 as positive, especially in an at-risk patient. Then you can presume that patient to have invasive fungal infection. And there's an equivocal, or where additional sampling, we're not quite sure whether this is positive or not, where additional sampling might be necessary, in fact, to just make it clearer as to whether or not there's a invasive fungal infection in those patients. We'll go through why sometimes you can get the equivocal and false positive in just a minute. what you need to remember is that there's certain clinical factors that can cause reactivity issues with the beta-D-glucan, and this can cause it to vary. If you have high fungal burden, sometimes you don't have a very good reactivity, and sometimes the site of infection also affects the reactivity to the beta-D-glucan and the type of fungus as discussed. The specificity of the test is from 87% to 90% on a single positive result. And that's very important. So it's very good in terms of ruling in presumptive fungal infection. So specificity increases to greater than 96 if you have more than one test, especially if these tests are sequential. So you've taken one today or 2 days, post that you take another, and they're all increased above 80, you can, without a shadow of doubt, then rule in invasive fungal infection with that in that instance. Sensitivity varies between 64 and 70. So as said, you can miss some of the patients with invasive fungal for reasons discussed just previously. Clinically, practically, how do we use FungiTel? You can rapidly diagnose invasive fungal disease, especially in at-risk populations. There is a wide fungal detection range as seen in that long list of different types of fungi that were listed there as being able to be detected or possessing beta-D-glucan in their cells, in fact. And also we have a higher sensitivity, specificity for invasive fungal disease as opposed to the sensitivity found in blood cultures. And relative to culture, it costs a little bit less. And in fact, it can predict therapeutic outcomes on patients who are on antifungal therapy. So falling levels, you can actually use those to demonstrate disease response. For example, in invasive aspergillosis, if you have that, it has been shown, in fact, in those patients who have a decreasing level will then recover from invasive aspergillosis as one of the actual uses. So there was a study that looked at using this in invasive aspergillosis, as it were. Increasing or persistently high levels in patients on antifungal therapy actually indicate a poorer prognosis and the fact that possibly antifungals may need to be reviewed. Limitations, like with any lab tests and challenges, you can get false positives with this assay. And also it's not limited in terms of it won't tell you which species is causing an invasive fungal infection. It just simply tells you that there is an invasive fungal infection. If you need to speciate, you do need to have cultures, but at least you can start with an antifungal in the meantime and hopefully improve your patient outcomes whilst you speciate using a culture. As mentioned, not all species have beta-D-glucan, and because of its semi-quantitative nature, if you get levels above 500, most of the time the lab will tell you above 500. So sometimes when your levels are very high and above 500 and you haven't been given an exact quantity, you do have to keep in mind that those patients might not necessarily not be responding to treatment. It's just that you don't know how high above 500 the levels have been. So that is some of its limitations. So you might have to call the lab up and interact with the lab for some assistance in that regard. So always, you never interpret lab results, as we know, on their own. We interpret it with clinical a picture of our patients. So these are some of the things that can cause false positive results. And in fact, bacteremic patients also can have false positive results, so please keep that in mind. Hemolyzed specimen, excessive manipulation of samples as well. You can see with the hemolyzed as well, the glucan, you get the glucan from tissue contamination. And then antibiotics like augmentin and piptazole actually can in fact cause false positive as well. So if your patient has been on those, please keep in mind, especially when you're getting those equivocal results, do check some of these parameters as well. What you need to remember though is that the performance of the assay is not affected by an antifungal. So even if the patient has an antifungal on board, if there's a beta-D-glucan in that bloodstream, we will be able to detect it. What the antifungal response is, you can look at the falling levels then, whether there has been response and the clearance of the fungus from the bloodstream. Hemodialysis with cellulose membrane. So cellulose, anything that has cellulose membrane tends to cause a cross reaction with the beta-D-glucan as well. And as we see there with human immunoglobulins, as well as albumin, coagulation factors, if your patients have received any of these and you're getting a positive in fact, beta-D-glucan or Fungitel result, please exclude these as potential things that could give you a false positive. So you always have to correlate clinically and keep in mind that these things can also cause a positive result. And in some patients where there's surgical gauzes or sponges still in place because those wounds haven't been closed, these can cause transient false positive in those patients, especially in surgical patients. What you need to keep in mind is that you do not take one single result or test in those specific patients. So if you do get a surprisingly raised Fungitel result, you do need to follow it up with the next Fungitel test, and a rise and a sudden fall actually indicates quite clearly that it was a false positive. So if there's a prolonged rise, so as you measure it, it's still quite there, and then it tapers off quite nicely, that is much more indicative of a true invasive infection than a sudden rise and a sudden drop. So do keep that in mind. I added galactomannan because we get asked on the differences between the two tests. So galactomannan is also a cell wall antigen in Aspergillus species. So it is specific to Aspergillus diagnosis and more importantly, invasive. So it tries to decide whether it's an invasive Aspergillus infection or not. It is highly specific to Aspergillus, even though the sensitivity has been reported to 30 to 100%, and that's sometimes why we use beta-D-glucan and can combine it with galactomannan if Aspergillus is specifically suspected, because the sensitivity is not as great depending on the assay used. And also you get also up to 83% false positives, especially in neonates. So in neonates, its use, you have to really keep in mind that you can get higher levels of false positives if using galactomannan. And also in patients receiving beta-lactams as alluded to, similar to beta-D-glucan. In fact, antifungals tend to lower its sensitivity in comparison to the Fungitel, and it tends to peak a lot later than Fungitel does. And as we said, in fact, depending on clinical settings as well, the sensitivity can be poorer. For example, it was demonstrated that in DIBA patients, sensitivity is better than in lung transplant patients. So keep that in mind. And those are mostly the patients where we're trying to, in fact, diagnose whether there is invasive aspergillosis. So summary of Fungitel. So the utility lies in the diagnosis, in the diagnosis of invasive fungal infections, because you get that result quite quicker, even though it doesn't speciate. And it is not a replacement for clinical and microbiological examination, obviously, because you do want to get to the species of the fungus, because that actually determines whether the treatment, the antifungal you have put your patient on, is actually going to be effective or not. And then lastly, of the ones I actually wanted to discuss is calprotectin. So I'm sending you right back, in fact, to bacterial infection diagnosis again. Calprotectin is not a new marker. It's currently in use. We just use it in inflammatory bowel disease diagnosis and differentiation between inflammatory bowel disease to, in fact, IBS. Irritable bowel syndrome, and it's usually in those instances measured on stool. So that's where we currently using calprotectin. But however, someone decided to use and look at calprotectin as a new biomarker in diagnosis of respiratory infection, in fact. And they used this together with a heparin binding protein, because both these are found in high levels in neutrophil granulocytes. Remember, neutrophils, especially for bacterial infections, were used as well as a biomarker for infection, are still being used. So if you have an increased white cell count and there's more neutrophils, this is more likely indicative. I mean, there's obviously caveats. It's more likely indicative of a bacterial infection versus when there is a lot more lymphocytes. So seeing that in acute bacterial infection, lymphocytes are recruited to sites, and these lymphocytes already have formed granules in them. And in these granules, there's heparin binding protein as well as calprotectin. Someone thought it a great idea to use as a marker for acute infection, obviously. So the calprotectin is found in the cytosol, as opposed to the heparin binding protein that's found, in fact, in the it's found in the where did I write that? Sorry, it's found in the azurophil granule itself. So in the cytosol of the neutrophil, you'll find more calprotectin. So what you need to remember as well is that it doesn't have to be formed, unlike the other two biomarkers of infection that I started off with. It's already there as part of the cytosol. So it can readily be released when a neutrophil responds, for example, to an acute bacterial insult. It is released upon activation and turnover of neutrophils, and it is recognized as an important marker for neutrophil-mediated inflammation, and therefore it's a surrogate for bacterial infection in that case. Activation of the innate immune system is the early defense mechanism, as we know, and with this gets recruitment of immune cells to the site of infection, and with this you get activation of complement cascade and activation of white cells to eliminate the microbes. So that's how all of that fits into being. And we know that in bacterial infection, neutrophil is the first cell to reach the affected site. And so that is why upon activation of the neutrophil, then the calprotectin will then be released, and therefore is looked at, or was thought of as one of the other markers that could be looked at, in fact, as opposed to PCT and CRP. What does data from clinical trials with regards to calprotectin, in fact, say? We know that it's being measured obviously in plasma, because if you measured it in serum, like we measure in PCT and CRP, then you would activate the process of actually spinning down serum, the serum tube, in order to analyze the serum activates, in fact, the neutrophils. So if you measured it in serum, it will cause activation of those, and then you get a false positive result. It was looked at, in fact, and was shown to be significantly higher in patients with bacterial respiratory infection, and in pneumonias, tonsillitis as one of the examples, than in patients with viral infections or healthy controls. And calprotectin and PCT were actually shown to be better at diagnosing bacterial pneumonia and mycoplasma pneumonia and streptococcal pneumonia as opposed to heparin binding protein. And also it was significantly higher than that for both PCT and heparin binding protein in discriminating between mycoplasma infections from viral infections. So there is clearly a lot of studies going on. We also ourselves looked at using calprotectin because we already have a way of measuring it. But at the moment, we do not offer, in fact, this specific biomarker just as yet. I also thought, that is actually put in wrong. I also thought to in fact highlight why calprotectin looked very appealing to us is because the method of measuring it can be applied in any chemistry analyzer in any of our labs. So it actually would give a very quick turnaround time if we actually opted to go along there. So I didn't keep up with how those studies went, how the performance of trying to see whether the assay was doing well or not for us to actually be offering it. So we didn't go ahead with it. So with this table, I just wanted to give you more or less the roles of biomarkers in sepsis as discussed, and also just to add the 4 last biomarkers, new biomarkers, and compare them whilst in clinical studies, I know, with the known biomarkers for bacterial infection. And you can see that in bacterial infection, CRP hasn't been recommended for its prognostic value, but for its diagnostic value, and PCT for both, especially in sepsis, respiratory tract infection, and the newer markers, especially as TREM1, has actually been shown to look very promising to prognosticate as well as a diagnosis for sepsis, pneumonia, and meningitis, because it's actually in fact produced in the meninges. So that's what that slide is for. And then in this table, as well, is just to highlight and to list some of the newer biomarkers, which I'm hoping I'll be invited again so that I can take you through them by clinics. And hopefully by the time I am invited again, then we can say whether they're in use or not. I've just simply listed them. And the one big one that is looking very promising is pre-sepsin. It seemingly is looking better than the rest of the biomarkers in terms of diagnosis and prognosticating. So with that said, I'd just like to conclude this very long yet summarized version of biomarkers by saying that it's actually quite important to use biomarkers in understanding infection and inflammatory states, so that you can at least get rapid diagnosis of these and can give your patients quickly the effective treatment that they may need that might actually improve their outcome. However, it is very important to understand that you don't look at these biomarkers on their own, and sometimes you don't look at the one biomarker, but you look at them in conjunction with the clinical picture of your patient, and then make decisions from there. But they certainly have a great role in helping improve the quickness with which we can diagnose infection, so that we can put our patient on the correct management as quickly as possible. So thank you very much for your attention. That concludes my talk with you.
Wow, thank you very much, Dr. Moeletsi, for this wonderful presentation. I think it's more than a summary when you say it's a summary. It's very detailed and gives us in-depth explanation and taking us back into clinical medicine, and also combining it with what happens in an approach setting, and also showing us the future of the use of biomarkers and what, and indeed, we'll definitely call you back to talk about the other biomarkers that you indicated in your last slide today. last but one slide. Thank you very much. It's quite a detailed presentation and a lot to absorb, such that some of the colleagues are asking for the copy of the presentation, if it's possible.
Yes, I most definitely will share with Kamo and team, no problem.
Okay, thank you very much. I will do so. We'll then share it with all those who have logged in this evening and via email when we do the surveys, and also for people to give us comments about how the presentation went. At the beginning, you indicated that one should be careful, I think, when you look at PCT in particular, that you should not use one lab and the following day use another one, just to check, because of the variability and also the choice of the assay methods that each lab is using. Is this within the same laboratory or across, I mean, in terms of groupings?
So usually same groups. Sorry to have interjected, Dr. Bila. Usually same laboratories will use a similar method. What we just simply checking, you are most welcome to use different labs. Just check, are they using similar methods? So you can ask the lab which method are you using, and that the next lab which method are using, in cases where you don't have a choice, because sometimes you really don't have a choice. There's already a result from a previous lab. You're just simply following up that patient. So just to check that they're using similar methods so that you're able to trend the PCT levels so you can manage your patient properly.
Okay. Thank you very much. And then you mentioned for the GPs, they can do your CRP tests. Are you refer this as a point of care whilst they are still waiting, I mean, before to decide when to refer? Is this a point of care or?
Yeah,
so I imagine that it might take a while to get the results. Patient is sitting there with you.
So with regards to point of care, I was just giving you clinical trial data that has also used PCT as a point of care to help GPs or in a primary healthcare setting decipher whether or not people can actually start antibiotics or refer to the next level of care in management of those patients. We most certainly do not offer point of care to GPs as the lab, because I mean, that's basically we do our own PCT formal laboratory test in-house in the labs, and most of the time that where labs are very close enough, it's a quick result to get back from labs. It's not complicated, it's not centralized, and ordinary labs, your nearest lab should be able to give you a CRP result quite readily, but there are point of care CRP tests available in the market. As labs, we just don't offer those to our GPs. We simply are saying clinical trials have shown a decrease in abuse in the primary healthcare setting of antibiotic misuse, simply because they claim that they don't want a patient to go home whilst they're not sure whether it's a bacterial infection. So they just willy-nilly give an antibiotic just to cover all bases. So these trials were simply just trying to demonstrate if that seemingly is a problem in the primary healthcare setting, you can have a point of care test. And it is quite useful in terms of decreasing unnecessary antibiotic use in that level of care to actually reduce your resistance rate in the communities as well.
Okay. Okay, thank you. And what is the turnaround time?
The turnaround time depends on how far you are from the lab. Okay, so the closer you are to the lab, it's not long. It's about if you have a lab that can perform the test within a 2-3 hour period, you should have your CRP level, even shorter, depending on how far you are. So I don't want to give an exact, because logistics aren't the same, aren't uniform everywhere. So I don't want someone quoting me saying, Dr. Moeletsi said the CRP is 30 minutes. Meantime, you are 2 hours away from a lab.
That's fair.
So you will get that result reasonably quickly in order to make a clinical decision. When you are within in a hospital setting, you obviously will get the result much quicker, that it can actually help inform your clinical decision making quite quickly. So it doesn't take long actually to get a CRP result. It's not like an FBC, which is 6 minutes. No, it's a little bit longer than that.
Okay, thank you. Okay, that's it. Dr. Tshegofatso wants to know, after how many days should we repeat CRP, PCT when patient is on antibiotics?
Yes, and like I said, so there is no guidelines in terms of exactly when a patient's PCT or CRP should be reviewed. Obviously, you need to keep in mind the cost effectiveness and as well the half-life or the rate of change of your levels. So anything between some people, if it's a critically ill patient, then they do need to actually check if there's good response quite quickly. Every second day should be fine. And even if it is a long-term sort of patient, you can check in 72 hours just to see how your patient, especially with CRPs, how your patient is doing. Or you can do it if you have money and you really need to know every day with PCTs, because they actually have a quick peaking levels. What you do have to remember is that you have to balance cost versus the need to actually do a lab test. You can see every other day should be sufficient for you to measure whether or not there's response to therapy.
Thank you very much.
Critically ill patients.
Okay. Yeah, thank you very much. We've I don't see any more questions on the chat group. I think there was one comment only that we should do antimicrobial stewardship rounds in the hospitals.
Absolutely agree. I think your infection control sister in one of the labs that that the hospital, especially clinics, hospitals that we work with, has contacted us to try and establish that, us and the other microbiologist, of course, because it's usually it's better when it's all labs that are servicing that specific hospital, so that you at least can get in fact input from all. I see there's Thabo Mashihu's hand that's up as well. Sorry, Dr. Bila, to just interject this.
No, that's fine. I say just briefly, Thabo.
A quick one, you omitted my question. Is that what you're saying to us is that the CRP it won't be a reliable test for somebody presenting with a liver dysfunction?
No. So what we are saying is that you have to keep in mind, because CRP is produced in the liver. So if someone has severe liver dysfunction, it can impair the ability to actually produce CRP. So in those patients, it might look like the CRP is not high. It simply might be because they can't make CRP. However, keep in mind, CRP is not just made in the liver. There's other cells as well that can make CRP. The lung as well can produce adipocytes as well. Other parenchymal cells can also produce CRP, but in the main, it is formed in the liver. Yes. Okay. But keep that in mind in severe liver disease.
No, thanks, Dr. Tshegofatso. My apology for that, for skipping your question. Okay, Prof. Wing, who's a member of the REST committee within Clinics Health Group, I'm going to ask you to do the final remarks before we close. Hope you're still there. Prof. Wing, are you still there? Yeah, you're still there. Please, if you can unmute yourself. Professor Wing?
Yeah. Okay, no, someone blocked my unmuting, so apologies for that. So thank you to the audience. So I want to thank everybody in reverse this time. So I think first and foremost, we must thank the colleagues who work in the back room, in the logistics of the clinics group, because they do this faultlessly every week to get 300 people on the Zoom platform and allow us to share this lecture. Secondly, to the clinics group for sponsoring this. I think it's an excellent forum for clinicians to learn and improve patient care. Dr. Billa, yourself, you tirelessly chair all of these every week, to the late hours. So thank you for your passion. Then to Dr. Moeletsi, it's always a delight to have a clear lecture that's able to harmonize and integrate basic sciences and clinical medicine. So it's very pleasing to be able to bring the laboratory to the bedside and assist clinicians in their decision making. I certainly remember during the heyday of the HIV epidemic, when public sector wards, certainly we did thousands of CRPs, thousands of procalcitonins and fungital assays weekly. And I would say without them, we would have had a much more challenging time managing those patients during the heyday of the HIV epidemic. So I'm very grateful that you are able to again solidify this balance between bedside medicine and the laboratory. So I thank you for your presentation and for again alluding to the value of this partnership between the laboratory and the wards. Thank you very much.
Thank you very much for those kind words, Prof. And thanks, colleagues, for joining us this evening. And we hope to join you, that you'll join us again next week. And just on the screen, and thanks to Dr. Moeletsi, we've thanked you, but cannot think more enough. And we are having our first in-person CPD meeting. It will be on the 11th of May at the Johannesburg Country Club. Please do join us. It's a full session, a full day session with more than 7 CPD points, we think. And thank you very much and have a good evening.